We would like to welcome Lars Lind, Linnaeus Chair of Medicine from Uppsala University. Welcome. So a brief reflection first of the discussion so far. What do you think?
Yeah, I think this is a very unique kind of thing that you bring all of these people together in this session. So I think it's worthwhile, and the first talks here has raised some thoughts in my head at least. So I think it's going along well.
And now we're going into a very delicate area of patient registers and primary prevention and the epigenetic studies. Please fill us in.
All right. I'm pleased to be here and share with you my vision about personalized health. And I cut down the title to just 2 words because the title in the program was very, very long. So, we all know that we are born with our genes, no doubt about that. And we all know that we got different kind of habits or lifestyle patterns. And we also know that some of these lifestyle patterns are good or harmful for your health. And if we, for example, take smoking, we know that it's not good for most of us, but we all know about this example that somebody told you that you get an uncle who smoked like a chimber and he was drinking like vodka like a Russian, and he still got 100 years old. So it's very evident that every bad thing is not good for everybody, and every good lifestyle pattern perhaps is not optimal for everybody as well. So I think that something that most people agree upon is that genes determine your susceptibility for certain lifestyle patterns. And now we, since like 7 and 8 years, have the tools to analyze the genome. And nowadays it's at a fairly affordable price. You can have your genome analyzed for about 100 euros. And by having this very nice tool in your hands as a researcher nowadays, we are collecting data for the next big step in medicine, which I think would be personalized health. And this is, of course, just one piece in the puzzle of perceiving a good health in the elderly population. But I think there will be a big step forward in this. And what do I mean with personalized health? It's actually about individualized advices on lifestyle modification. And this is also applicable to medication, and in that sense we are talking about personalized medicine. But we are not there yet. We don't have the data there, so we can give these individualized advices in a meaningful sense, that we have robust data to support the advices. And it will take another 10, maybe 20 years before we are there. But we are working with this, and we're collecting the data, analyzing the data, and working with this problem to get what's needed for this new concept. What we are doing here in Uppsala is running the EpiHealth cohort study. And that's one piece in this big data collection. And the EpiHealth cohort study aims to collect data in about 300,000 Swedish subjects, being middle-aged up to the elderly. And it's a collaboration between Uppsala and Lund University that started some 3 years back now. The primary aim is to look at interaction between lifestyle patterns and environmental factors and the genes concerning development of the common disorders that occurs in the elderly. And in practical, what happens is that you get invited into being a part of this study, and you start with answering a questionnaire, come back to that one. Then you go to visit to a test center where we collect blood and DNA, and we perform some physical examinations like blood pressure, height, weight, etc. We measure glucose and lipids. This is a brain function test. We also look at lung function and ECG. And then we follow this cohort in the future. What happened with people, which kind of diseases do they get, etc. And here are just some examples of the lifestyle factors that we include in this questionnaire. It's some very basic things that's collected in every study, I think, like what you eat, alcohol consumption, smoking, etc. But we also have quite a lot of questions about physical activity, the work, life history, about your what you feel about your working place, etc. Pain history, injury history, and also a lot about environmental exposures. So this would be the basis for looking at the lifestyle. We also have the privilege in Sweden to have a lot of very nice national registers that we can link our data to. So here is just an example of some of those where we both can get data on exposures like education, family members, sick leave, etc. But also on if people got the kind of disorders and diseases that we are looking on. There is a similar initiative in Sweden that started a couple of years earlier than the EpiHealth study called the Life Gene. You probably heard about that. It originates from Karolinska Institute. They basically look at people from birth up to middle age, and we see Life Gene and EpiHealth as sort of two sister studies where we continue from middle age up to the elderly. So we share the same computerized system, we have common information on exposures, and we have common physiological testing. So in Sweden we have in some years to come a very big collection of data from the birth up to the elderly concerning lifestyle, genes, and health. So we are not doing this in Sweden here as sort of a kind of isolation. This is going around at different parts of the globe, and there are countries that are far away ahead of us. The UK Biobank has collected data already in 500,000 subjects. At Iceland, they have collected genetics and health information in about everyone living there. In the Netherlands, Lifelines are collecting data in families and have about 200,000 in their data records. In Estonia, they have a very promising initiative now reaching about 100,000 people. And in US, they started a very big study in US veterans, aiming to collect data in 1 million subjects. And there are initiatives in China, Germany, etc., building up these kind of population-based health registers. And I think since this is very complicated, looking at multiple lifestyle factors and multiple genes, we need very, very large studies in order to have the statistical power to get robust data that we can use for individualized health counseling in the future. So this large amount of data actually have to work together across the globe internationally in order to get all the information that we need for the personalized health concept. So, a vision that I have and a lot of other people as well is that we in the future should build sort of health centers. It could be a part of the existing structures, but it could also be some brand new thing. And the concept is to preserve health up to high ages in the elderly to have long, to prolong the healthy years in the aging populations. And the backbone will be individualized health counseling using modern technologies, and most important, also provide long-term feedback on these behavior. Because the problem, if somebody is told that, oh, you got to change that and that, you got to quit smoking or drink less, most people could do that for a limited time if they are motivated. But the problem is to keep this sustained for years and years and years. So that's a major challenge in this concept. And this is how, how I look upon this kind of health center. It will be a meeting between three people. The individual that's been invited to this health center, a physician, and a health coach. Much what some people do when they go to a gym, they sort of hire a physical coach to coach them how to proceed. We like to have a health coach that's sort of coupled to a certain individual. The idea is that these people should have access to a lot of data on this individual. So we have the sort of traditional kind of things that we got in healthcare, like a history of disease and medication, and a physical examination, but also detailed information on the genes and other kind of omics technologies that are emerging right now, like metabolomics and proteomics. And metabolomics is here right now. We are just beginning with that. Proteomics will take another maybe 5 years because we can utilize that in large scale. We also would have detailed information about the individual's lifestyle and behaviors, and also perhaps in the future we would add advanced imaging of the body, like magnetic resonance imaging of the total body. The thing though is that we should unite all these data on the individual together with this information that has come out of the big studies like EpiHealth, UK Biobank, etc., that will give sort of robust data on interaction between the lifestyle and the genes and metabolomics, etc., so that we can, in a meaningful and robust and serious way, give this individual that's been invited an individualized health counseling. So let's say that this guy who is pretty lazy, just sitting most of his time in the sofa watching football, will have the advice that by increasing his physical activity to being out jogging twice a week, he will lower his, with his particular genes, he will lower his risk of getting a myocardial infarction, lower that from let's say, a third of what he otherwise should have. He might think that it would be worthwhile to take on that effort. And then he will be coupled to this health coach who will help him with embarking on such a training program. And the thing here is, with time, this individual should receive continuous feedback on his or her health performance. So in terms of myocardial infarction and exercise, it's pretty obvious that it could affect the body weight, the fat distribution, the lipids in the bloodstream, the glucose levels, the blood pressure, etc. So this individual will be having a lot of technical solutions. Some are here already, like wrist watches for looking at blood pressure and heart rate, etc. But also new devices that will give feedback to this individual how he and she is performing in sense of improving health. Because I think that would be one key issue in order to be successful in these kind of things is that this individual have to keep moving for a long time, and one way to get people motivated is feedback, so the subject could see that the health is actually improving. And the health coach should also receive this feedback and sort of pushing this individual at regular time point. It could be by internet, it could be by personal meetings, etc. But we need somebody who will push us in this sense. And also the physician will now and then get feedback just in order to see how this individual is improving. So that's a vision how we can improve health for the future. So to summarize then, we now have the tools for this personal health concept to build the data banks, to do the statistics, to build the things that needed to get to give these individualized advices, but it will take another 10 years before we have these data, and that time we can prepare to, at least in the minds and then later on in practice, build these kind of health centers for individual health counseling and coaching to improve the health in the elderly population. Thank you.
So exciting. Thank you, Lars. I'm thinking about these health centers. In your view, is this a public responsibility or is it private actors, or what do you visualize?
Well, I don't know, actually. Hopefully, the politicians will think these kind of ideas are so very important that they would supply this kind of health center for the entire population. If that's political correct, or if they think this is just another way to waste money because they need all the money for taking care of the elderly, not to prevent sickness in the elderly. We don't know, but that's at least my vision, that the society would supply these to all the members in the society.
Could we please, if you please stay, and Mentimeter 3, if we would get the most efficient prevention measure, because that's interesting to hear the audience view. Is it the self-control that is the most efficient prevention measure? Is it the state control? Is it the social guilt? You are guilty of when you smoke and you don't take care of your health. Effective screening and early detection, is that the most efficient prevention measure? Health education in general, or the health maintenance coaches, the ones that you've actually described? Well-targeted financial incentives, they could be both from the providers and the individuals, or the culture that we would foster, living life to the fullest. Will that be an efficient prevention measure in itself? And again, it could be, of course, be all a mix. But please pick your favorite. What would you pick, Lars?
Well, I think we need to work at this level, of course, because I told you about that.
Yeah.
But we need also this more broad education thing. I think these two, I would go
5
for
and 6. We'll
yeah.
see if you're representative for self-control is very important, again, with the individual attitude of the Swedes. And the screening is very popular, and of course the educational part. Health maintenance and living life to the fullest culture is also very popular. I can, and personal experience from this health education, my mother was operated for colon cancer last year, and when I saw what kind of diet she was provided in the hospital, a specialized hospital, she would get skorpor, which is a flour, dry flour buns, and saftkräm, which is a chemical sweet sugar thing. That's what they thought would really bring her health back. And I think it's the health education, not least in the profession, is scary at times, what we can do to prolong healthy lives. Your reflection?
Yeah, sure. You're totally right.
Yeah, because this is obvious. One more, when it comes to the fact that is delicate for many, Mentimeter 4, please, the testing for personalized prevention. Some think that this is and I'm talking about the gene technology, genomics, which is some are extremely reluctant and really dislike it. Should it be a human right to get this testing, the measurements? Should it be mandatory even, or optional? Should it be mandatory when your family has a hereditary disease, which some recommend, like breast cancer or other difficult diseases? Should it be offered if society can provide the necessary treatment? Because sometimes they will identify a risk, a mutation that is really a high risk, but unfortunately we cannot afford, or in other ways have the resources to deal with it. Or is the whole idea of personalized testing at that level that Lars has been describing too expensive altogether, or should be abandoned? Just to get an overall view of what you would prefer out of these alternatives. What would you have said, Lars?
Well, I think in the long run it should be a human right.
Interesting. Again, we'll see if you are offered, if society, because this is, of course, can be extremely painful to know that you are at risk, but unfortunately it costs $160,000, we can't help. Optional is the preference of the audience. This really invites us for discussion, and you will be able to have a nice coffee break while discussing all the things that have been brought up. Thank you again, Lars. And